and welcome to this webinar, New Paradigms in the Management of Hereditary Transthyretin Amyloidosis Mixed Phenotype, ATTR-V, CM, Cardiomyopathy, and PN, Peripheral Neuropathy. I'm Dr. Michelle Kittleson from Cedars-Sinai in Los Angeles, and I'm joined with my amazing colleague, Dr. Chafic Karam, Professor of Neurology at University of Pennsylvania in Philadelphia. So here's a summary of all the amazing credits you can receive for continuing medical education. We have disclosures and disclaimers here. And regarding the planner and speaker disclosure policy in accordance with ACCME standards is shown here. And regarding our specific disclosures, you can find the details of those on this slide. Our learning objectives are to summarize the characteristics, related disabilities, and comorbidities, appraise the role of imaging in the diagnosis, identify novel treatment options for ATTR-CM and peripheral neuropathy, and implement interdisciplinary care. For the agenda, we'll have pre-test and post-test questions, so make sure you respond. That's super helpful to figure out how much you know and how much we can teach you. I will talk about the diagnosis and novel treatment options for ATTR-CM, and then I'll pass the baton to Dr. Karam, who will discuss the diagnosis and novel treatments for ATTR-PN, and we'll end with 15 minutes of a panel discussion and all of your burning questions, which we cannot wait to answer. So let's start with that first pre-test clinical vignette. Which of the following patients with dyspnea on exertion should be evaluated for transthyretin cardiac amyloidosis? You see the poll popping up on your screen. A 24-year-old woman with scleroderma and severely elevated pulmonary artery systolic pressure on echo. B, a 78-year-old man with increased left ventricular wall thickness on echo, carpal tunnel syndrome, and a family history of heart failure. C, a 44-year-old woman with spontaneous coronary artery dissection 3 years prior. Or D, a 54-year-old man with hypertension, diabetes, obesity, and ECG showing high voltage consistent with left ventricular hypertrophy. Okay, let's see. Put in your answer. Doesn't matter if you're right, doesn't matter if you're wrong. Put your nickel down, and then we'll see how if I can convince you of the right answer by the end of my talk. Okay, perfect. Well, this is fantastic. We have a pretty good spread on the responses, so thank you for responding. No one thought it was the woman with scleroderma. About half of you thought it was the 78-year-old man with the increased wall thickness. And then there's about a quarter who were split between the woman with SCAD and the man with hypertension and diabetes. So let's see if by the end you change or keep to your current response. Okay, moving on. So let's go straight into the talk. I have no relationship to disclose, so let's start with a different case and see what we can learn from it. A 72-year-old woman presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorothalidone, amlodipine, and ibuprofen as needed. On exam, her BMI is 31, heart rate 68, blood pressure 142/88, JVP elevated at 10, S4 gallop, 2+ edema. Her echo shows mild increased LV wall thickness, EF 60%, mild aortic stenosis, and mild pulmonary hypertension. If this 72-year-old woman walked into your office, dyspnea, edema, comorbidities, preserved ejection fraction, what would you think is the most likely diagnosis? And would it be cardiac amyloidosis? Would it be heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, aortic stenosis, pulmonary arterial hypertension? Well, what you may use to come up with the right answer is the H2F PEF score, which outlines 6 readily accessible clinical variables into a probability that your patient has HFpEF. So if we took this 72-year-old woman in your office and we assigned her points, her BMI is above 30, she's on 2 or more antihypertensive, she has AFib, her PA systolic is elevated on echocardiogram, she is older, she has a score of 8, it's pretty much a slam dunk that she has heart failure with preserved ejection fraction. But what if I tweak her a little bit? She's still a 72-year-old woman, but now she has a more indolent course. She has fatigue and shortness of breath. She is no longer has hypertension, but she has paroxysmal atrial fibrillation. She no longer has osteoarthritis, but now she has bilateral carpal tunnel, spinal stenosis, peripheral neuropathy. Her medications no longer include those antihypertensives. On exam, she's no longer obese, no longer hypertensive. JVP is a bit worse, but the echo looks exactly the same. So if you went to your H2F PEF score and calculated it on her, and I asked you what's the most likely diagnosis, I'd like to convince you that it's different. Her H2F PEF score is actually 5. It gives her still a reasonable probability of HFpEF, but does she have HFpEF? So I do this exercise to illustrate the challenge in the diagnosis of someone with dyspnea, edema, and preserved ejection fraction on echo. Because HFpEF, the garden variety heart failure with preserved ejection fraction, is ultimately a diagnosis of exclusion, which can be the hardest diagnoses to make. And it's important to rule out other things for which there might be disease modifying therapy, like a restrictive cardiomyopathy, a hypertrophic cardiomyopathy, valvular heart disease causing symptoms, predominant right heart failure, obstructive lesions, pericardial disease, or high output heart failure. Now, the good news is an echo will help you exclude many of these. Your history will never let you down. But when that patient presents to your office with dyspnea, edema, and a preserved ejection fraction, think about those clues that it's not your garden variety HFpEF. Maybe they're younger. Maybe they don't have the typical comorbidities of the hypertension, diabetes, coronary artery disease, obesity. Maybe they have a different rhythm and a trajectory. So every disease has a classic rhythm and trajectory, and the longer you live in medicine, the more you internalize them. And HFpEF is typically a disease of quiescence punctuated by exacerbations with readily identifiable triggers. Like you feel okay, and then you take an NSAID and you get terribly volume overloaded, and then you go back to feeling okay. Whereas cardiac amyloidosis has a much more slow but progressive and inexorable decline. Think also about that QRS voltage on the ECG. If you have left ventricular hypertrophy on your echo, those volts should be normal or high. If they're discordant, they don't quite fit, that is a clue you're not dealing with garden variety HFpEF. So when you look at that echocardiogram report, sometimes it says left ventricular hypertrophy or LVH. I don't like that. Why? Because LVH presumes that it's muscular hypertrophy, too much muscle. But if the wall thickness is high, it could also be infiltration into the muscle. So if a report says LVH, make sure you automatically in your head say, I don't know if it's muscle, it might be infiltration into the muscle. Don't anchor away from half your differential. Now, if it's too much muscle, it could be explained by loading conditions like hypertension, valvular disease, athlete's heart. It could be unexplained, which by definition is HCM, but it could also be infiltration into the muscle when by far the most common source would be amyloid cardiomyopathy. So, this is how I like to think about it. The patient walks into your office with dyspnea, edema, and a preserved ejection fraction. Question number one, is it the heart's fault at all? Maybe it's the heart's an innocent bystander, and the congestion is from the kidney, the liver, or chronic venous insufficiency. It's very hard to unring the bell of misinformation. And if your patient has been told they have heart failure, but it's actually driven their congestion by kidney or liver, that's hard to backtrack. So make sure you know to begin with which organ is the problem here. Now, if you're convinced it is the heart's fault, then ask yourself, is there an underlying condition for which there is disease modifying therapy, which you would never want to derive from your patient, deprive from your patient? And finally, if you're convinced it is garden variety HFpEF, pay attention to the comorbidities. Now, I'm never one to advocate for more testing, but I'll always advocate for more thinking. So you run through this differential to make sure you're not missing an infiltrative cardiomyopathy. So, how do you know? How do you run through this differential? Well, think about cardiac amyloidosis, which is a condition where there is a protein that the body produces naturally that, for reasons we do not understand, decides to go into the heart, causing a restrictive cardiomyopathy. The protein, there's about 100 different ones, but there's really only two you need to know about. The two most common sources of the protein will be immunoglobulin light chains, AL cardiomyopathy, which is a plasma cell dyscrasia along the spectrum from MGUS to multiple myeloma, or the TTR protein, ATTR-CM, transthyretin protein, which is a binding and transport protein in our bodies, which in turn can come from one of two sources, either a mutation in the gene, that's the variant form, or wild type gene, and that's ATTR wild type. Now, in the olden days, we used to call wild type ATTR-CM senile cardiac amyloidosis. We don't do that anymore. It hurts people's feelings. So the proper terminology is AL cardiomyopathy, ATTRv, or ATTR wild type. And here's your clinical clue to have a high index of suspicion. This protein just doesn't go to the heart, it goes other places as well. There can be a neuropathy, as we'll hear from Dr. Karam. There can be a nephropathy unique to AL, gastrointestinal involvement, and the highest yield will be the orthopedic musculoskeletal issues, classically carpal tunnel and spinal stenosis. So think about having this high index of suspicion where the heart failure symptoms are but the tip of the iceberg. Be aware of what lies beneath. There can be other cardiac manifestations, AFib, AV block pacemaker. There could be severe aortic stenosis or HFpEF. Note that in case series of patients with AS, older patients with AS, or older patients previously diagnosed with garden variety HFpEF, if you screen them, about 15% of both cohorts will have underlying TTR cardiac amyloidosis. So don't miss the diagnosis in those cohorts, especially if there's increased LV wall thickness with discordant QRS voltage, if there's a sensory neuropathy, if there's autonomic dysfunction, classically intolerance to vasodilating antihypertensives due to orthostasis, if there's orthopedic manifestations like bilateral carpal tunnel at an older age or spinal stenosis. So, with that, if I take you back to the patient, it jumps out at you. So much of medicine is pattern recognition. And when we look at this woman, we say something's funny here. She is not hypertensive. She doesn't have the classic comorbidities of HFpEF. She has increased LV wall thickness, but I can't explain it based on her lack of hypertension. And these seemingly disparate findings, like the carpal tunnel, the spinal stenosis, and the neuropathy, come to a satisfying, unifying diagnosis. So apply this pattern recognition to your patients. That is the first hurdle. The second hurdle is to order the right tests and interpret them in the right way. Because cardiac amyloidosis is not a condition that's going to jump out at you on routine testing. You have to look for it in order to find it. So, first, you're going to want to rule out AL cardiac amyloidosis with a monoclonal protein screen. If the monoclonal protein screen is abnormal, you do not pass go, you do not collect 200. You remember that tissue is the issue and you biopsy something to exclude AL cardiomyopathy. If the monoclonal protein screen is negative, you give thanks because it's a better prognosis to have ATTR-CM, and you order a radionucleotide scintigraphy scan, which, if positive, cements the diagnosis of ATTR, and then you can do genetic testing to figure out wild type or variant, useful for cascade screening of first-degree relatives. Now, there's some subtleties to this diagnostic algorithm that we'll discuss. Monoclonal proteins. First, I remember memorizing in medical school SPEP, UPEP, amyloidosis. Not enough. SPEP, UPEP is not as sensitive as immunofixation electrophoresis. Don't just order the SPAP, order the IFE. Second, I remember memorizing in medical school fat pad amyloidosis. Not true. Fat pad lacks sensitivity. It's more convenient to do a fat pad biopsy. It is less invasive, but it has less sensitivity. So if it's negative, you can't stop there. You must biopsy the organ of interest as the gold standard to exclude ALCM, typically heart or kidney. And finally, these bone scintigraphy scans, like the technetium pyrophosphate scan, are a huge advance, allowing the non invasive diagnosis of ATTR-CM. However, they're diagnostic only if the light chains are negative. Why is that important? 10 to 20% of patients with AL will have a false positive technetium scan. The median untreated survival of AL is less than a year. So if you just do the technetium scan and it is positive and you treat them for ATTR and you miss a diagnosis of AL, you are giving the patient a death sentence. So make sure you always interpret your technetium scan in the context of a negative monoclonal protein screen. This is all formulated in the 2022 heart failure guidelines. And let's move on now to hurdle number 3, which is therapies. Remember, hurdle number 1, think of the diagnosis. Hurdle number 2, order the right tests and interpret them in the right way. And hurdle number 3, therapy. So when we look at therapies for ATTR-CM, we think about it in targeting this protein that is doing something bad. TTR, not a hugely important protein. So, one way that you can treat it is by stopping production. In the olden days, that was through liver transplantation, which is quite extreme. Fortunately, we don't need that so much anymore because now there are mRNA silencers, which we'll talk about. The second way is to take the protein and stabilize it in its happy tetramer form so it does not misfold and go into tissues. That's the stabilizers. The holy grail, which we'll talk about, though not ready for prime time, would be these depleters where you suck it out of tissues and reverse disease. What we have currently available for use are stabilizers and silencers. Let's talk about the evidence. Tafamidis, a TTR stabilizer, is a treatment that works. The classic landmark ATTR-ACT trial came out in 2019. Actually, the late-breaking results were presented in 2018. They found that if you give tafamidis versus placebo to patients, you have a 13% absolute reduction in mortality, absolute, not relative, over 30 months, and a reduction in heart failure hospitalizations. The trial came out late breaking 2018. Less than a year later, the FDA approved it based on the strength of this evidence. 2 important things to know about tafamidis. Number 1, it will not make patients feel better because it does not reverse disease. You're starting it to prevent them from feeling worse over time. Second, the earlier you start it, the better they will do. That is shown in clinical trials. And also, you want to try to freeze them as early as possible in their disease course so you can preserve that level of functional capacity and quality of life. So that's the first stabilizer on the market. Now we have acoramidis, another TTR stabilizer studied in the ATTRibute-CM trial, similar design. Acoramidis versus placebo met their primary endpoint, which was a win ratio of hierarchical death, adding a hospitalization, NT-proBNP. That's a bit hard to understand. So they actually had a secondary analysis focusing solely on hazard ratios for all-cause mortality and first cardiovascular hospitalization. So comparable to the ATTR-ACT trial with tafamidis, and it works. And because it works, and because the trial was positive, acoramidis was approved in late 2024. So 2 stabilizers available for use: tafamidis, acoramidis. But there's another mechanism, right? And that other mechanism is the TTR silencers. So Dr. Karam is going to discuss with you their current evidence, which was in neuropathy. We have Apollo and NeuroTTR. It reduces progression of neuropathy if you have the variant form. Then we had some post hoc analysis with surrogate endpoints. They offer some benefit in cardiomyopathy. Then we had some early trials in cardiomyopathy. One stopped early due to deaths in the treatment arm. The other had a kind of less clinically important endpoint of 6-minute walk distance. And so not very exciting. Patisiran approval was denied. However, there's more. And this is exciting. The landmark Helios B trial. 655 patients with ATTR-CM, vutrisiran, a silencer versus placebo. A lot of patients also on tafamidis because you couldn't withhold an FDA-approved therapy, but the primary endpoint was met: death, cardiovascular events, preservation of 6-minute walk distance, and quality of life. Based on the strength of this data, it's approved by the FDA. So now we have 3 medications to offer patients with ATTR-CM: 2 stabilizers, tafamidis, acoramidis, and 1 silencer, vutrisiran. Stay tuned. There's another silencer coming down the pike. Actually, that should say 2026. The results will be available in 2026. So if we have an embarrassment of riches going over 5 years ago from nothing to offer our patients, and now to have 3 medications, what you really want to know is which medicine should you choose? The problem is clinical trials cannot answer this question. So if you look at this summary of the key studies: ATTR-ACT tafamidis, ATTRibute-CM acoramidis, HELIOS-B vutrisiran, they were very different trial populations. As I've highlighted here, patients were far less symptomatic if you look at successive trials that enrolled in different eras. We look at NT-proBNP, it was a lot better. Their 6-minute walk distance was higher. Their quality of life, as measured by KCCQ, was better. What does this tell us? It tells us that as we got better at early diagnosis and other things like heart failure management, patients with cardiac amyloidosis enrolled in trials reflective of the general population of amyloid patients were getting healthier and healthier and healthier. So you cannot compare the outcomes of these trials to say which is better than the other. It's like comparing apples and oranges. That's also shown so beautifully in this survival curve analysis here, which overlays the survival curves for the treatment and placebo arms of the 3 landmark trials. Patients in ATTR-ACT did far worse than patients in ATTRibute-CM, who in turn did far worse in patients with HELIOS-B. Even the placebo arms of successive trials did better in the treatment arms of the prior trials. And look how incredible that dark blue survival curve is. That's a treatment arm of HELIOS-B. And what can you see? That in the current era, survival of patients with cardiac amyloidosis approaches their age expected mortality, which is related to early diagnosis, better heart failure management, and the presence of disease modifying therapies. So trials can't tell us which one is better. Trials can't tell us if combination therapy is better. So here's my take. First, you confirm ATTR amyloidosis because you pass challenges 1 and 2. You think of the diagnosis, you order the right tests, you interpret them in the right way. The first question you ask yourself is a hard question. Is there end-stage disease? Remember, these therapies do not help people feel better. They do not reverse disease. They slow or halt the progression. So if someone is already end-stage, very poor functional status, symptoms at minimal exertion or rest, bad kidneys, terrible blood pressure, poor biomarkers, it is unlikely they will derive benefit. And that's a tough conversation of knowing when it is better to say no than to say yes. But if there's not end-stage disease, then you have to ask, are there any non-medical characteristics that would guide you towards therapy? What might a non-medical characteristic be? Cost. Is there a payer preference? If there is, because all 3 of the therapies work, pick the cheapest option for your patient. But if there is no financial slant, then ask if they have neuropathy, because where there's data with the silencers, but not the stabilizers, with the neuropathy, I would use vutrisiran. And finally, if there isn't any compelling medical indication, ask them if they have a preference. Maybe they want a medication that they take every day, or maybe they want a medication like vutrisiran that's subcutaneously delivered every 3 months in a healthcare setting. So that's my take on how to decide amongst the array of therapies. So we can say with confidence, no one of these is better than any other based on evidence to date. Combination therapy has not demonstrated benefit. So when you're picking the one therapy to give your patient, think about cost, neuropathy, and preference. What about guideline-directed medical therapy for heart failure? We all know how incredibly important that is in HFrEF and HFpEF. These are snippets from the heart failure guidelines telling us the strong evidence for these. But I want you to think differently in cardiac amyloidosis. I want you to think differently in restrictive physiology, in the stiff heart of cardiac amyloidosis. Remember the pathophysiologic consequence of a stiff heart, which is a fixed stroke volume. So if the heart's stroke volume is fixed, then you need your heart rate to maintain your cardiac output. So things like beta blockers are poorly tolerated, can lead to a lot of exertional intolerance. So often we avoid beta blockers. Second consequence of restrictive physiology and a fixed stroke volume is that you cannot increase stroke volume in response to afterload reduction. So in your standard HFrEF patient, if you afterload reduce, that is vasodilate them, lower their blood pressure, their heart will feel so happy. There's less to pump against, and then they can pump more effectively and increase their stroke volume, which is why you give these vasodilators like ACE-ARNI-ARB to patient with an HFrEF, and their blood pressure systolic doesn't change because you might be giving them a vasodilator, but they're offsetting that effect by increasing their cardiac output. That doesn't happen if you have a fixed stroke volume. So often, if you give a vasodilator to a patient with restrictive physiology, you will just make them hypotensive, tachycardic, and potential orthostatic and acute kidney injury. So if a patient comes to me with ATTR-CM on ACE-ARNI-ARB or beta blocker and they feel okay, I'll continue them. But if there is concern for exertional intolerance, symptomatic orthostasis, or worsening kidney injury, I have a low threshold to back off on those agents. One other thing I'll say is, however, there is some preliminary data to indicate that there is benefit from mineralocorticoid antagonists and SGLT2 inhibitors to relieve congestion. So in a way, you're treating ATTR-CM similar to how you treat HFpEF when it comes to guideline-directed medical therapy. Avoids the vasodilators and the beta blockers, the ACE-ARNI-ARBs, the beta blocker, but consider the MRA and the SGLT2 inhibitor. So I want to give you some glimpses into the future. So we talked about silencers, which inhibit mRNA, so the proteins are not produced. But there's another way to silence TTR, which is with gene editing, where you send an mRNA for TTR into liver cells to alter the TTR DNA, permanently silencing production. We know in early studies that you can get 90% knockdown of the protein at 12 months. Am I interested in these glimpses into the future? The short answer is not really. I think it's just a fancier way of giving an mRNA inhibitor like vutrisiran. And I think what we really need to establish is the safety of the potential off-target effects of gene editing and the cost of giving a one-time therapy, which likely will be priced very high to make it economically feasible. The glimpse into the future, however, that I'm hugely excited about is shown in the figure on the right. This is antibody depletion, where you send a monoclonal antibody that binds only to the misfolded TTR amyloid fibrils, which leads to antibody-mediated phagocytosis and removal from tissues. This technology has a potential to reverse ATTR-CM, reverse the damage, help patients feel better. And this has been shown in early studies with reduction in imaging-based surrogate markers of amyloid load. There are currently trials ongoing, so we should know more in the next few years about where this will fit into our armamentarium. So if a patient has ATTR-CM or you think they have ATTR-CM, when do you need to refer to an amyloid specialist? As I hope I've demystified for you, it's a pretty straightforward condition. Think about the diagnosis, order the right tests, interpret them in the right way, and implement therapy. And the therapies are quite straightforward in that they don't have interactions or monitoring protocols. But there are some times where an amyloid specialist will be very helpful. Maybe you're not sure of the diagnosis. Maybe the scan is equivocal. Maybe the monoclonal protein screen's abnormal, and you're not sure what the next step in the diagnostic algorithm should be. Maybe treatment is uncertain because these medications have a sticker price in the hundreds of thousands, and no patient ever pays that much, and therefore can be very tricky to prescribe. And if you need the support of a tertiary center, amyloid referral center for prescription support, you may want your patient to have access to clinical trials. That's a good reason to send to an amyloid specialist. Or finally, if you believe they're a candidate for advanced therapies like transplant, then it's useful to refer. So, those are the four reasons I think it's useful to get an expert involved. So, in summary, what do we know? We know that ATTR-CM is more common than you think, particularly in those HFpEF patients who also have musculoskeletal manifestations, have a high index of suspicion in the face of clinical clues. Number two, non-invasive diagnosis is possible as a technetium scan is diagnostic in the presence of a negative screen for monoclonal proteins. Remember, you must or exclude AL first, and that tafamidis, acoramidis, and vutrisiran are effective, evidence-based, and FDA-approved therapies. We still need to know what standard of care should be. Is it a stabilizer? Is it a silencer? All we can say right now is they all work, so pick the one that makes sense based on cost, neuropathy, and patient preference. We also do not know currently how do you assess response to therapy, and even if we could assess response, what do you do about the non-responders? And we don't ultimately understand if we get too good at diagnosis, how should asymptomatic patients be managed? Well, thanks so much for your attention. It's really been delightful. We're going to move now to the post test clinical vignette. All the wisdom I just shared with you. Let's see what you think about that question. Which of the following patients with dyspnea on exertion should be evaluated for ATTR-CM? 24-year-old woman with scleroderma, severely elevated pulmonary artery systolic pressure on echo, a 78-year-old man with increased LV wall thickness, carpal tunnel, and a family history of a 44-year-old woman with spontaneous coronary artery dissection 3 years prior, or a 54-year-old man with hypertension, diabetes, obesity, and an ECG showing high voltage consistent with LVH. Okay, put in your answer. Doesn't matter if you're right or wrong, put your nickel down so we can see what everyone thinks. Right, I'm waiting for the answers to come up. Here we go. Excellent. Okay, the correct answer is a 78-year-old man with increased LV wall thickness on echo, carpal tunnel, those musculoskeletal manifestations of the amyloid protein going into the carpal tunnel, and a family history of heart failure, thinking he might have the variant form of ATTR-CM. A 24-year-old with scleroderma, well, that causes severely elevated PA pressures. That wouldn't make sense because young patients don't get it. A 44-year-old woman with SCAD, so spontaneous coronary artery dissection. I didn't mention it a single time during my talk because it has no relation whatsoever with ATTR-CM. And finally, the last guy is sort of a classic setup for HFpEF. He's got the comorbidities of the hypertension, diabetes, obesity, and his ECG shows high voltage. So his increased wall thickness on echo is likely from the hypertension. So think of that older man who has increased wall thickness, carpal tunnel, and a family history of heart failure. Wonderful. And now I will pass the baton on to my colleague, Dr. Karam. I'm going to unshare so he can share his slides.
Thank you, Michelle, for this excellent presentation. And for talking about ATTR cardiomyopathy, or CM. As a neurologist, I'm going to discuss my area of expertise, which is ATTR-PN. And most of these patients are going to be of the genetic variant. So we're going to put V as variant for polyneuropathy. So let's do this case. This is a straightforward case because this patient already has a diagnosis of V30M TTR and polyneuropathy, and he's been already on treatment for 3 years. And he's been doing fine with that. He has a little bit of cardiac involvement, according to the PYP scan and a cardiac ultrasound. He doesn't have symptoms, though, which is a common scenario in this specific mutation, especially if you start treatment early on. So no shortness of breath, no swelling in the legs. However, he watched TV and he saw an advertisement about the new TTR stabilizer. And he is wondering if he should switch from the silencer to the stabilizer. So this is the questions that we have. Would I recommend, or would you recommend, not switching, but instead using a combination therapy, a silencer and a stabilizer? And if you're listening to Michelle, you would probably know the answer here. Switching to stabilizer, since oral medication is more convenient and would target the heart. Repeat the cardiac workup and see if there's progression of disease to help with the decision of switching versus staying on his current treatment. Or suggest adding diflunisal, which is an off-label TTR stabilizer, but much more cost-effective than the FDA-approved one. And then E, reassure the patient that he is on adequate therapy and no change is necessary. So I think Michelle gave you the answer before. I'm not sure my talk will add much, but let's see the results. So most of you have said maybe repeat the cardiac workup and see if there's progression of disease to help with the decision of switching versus staying on the current treatment. Nobody said switching to stabilizer since oral medication is more convenient. And a small percentage of you said not switching, but instead adding. And then finally, the minority said reassure the patient that he is on adequate therapy. Okay. So let's talk about ATTR-PN and how to diagnose patient and how to treat them as well. These are my conflicts. And when we see patients with amyloidosis or neuropathy that we think is related to amyloidosis, the major probably thing that we're going to be thinking about is the genetic TTR or the AL. These are the most common two that we see in our neurology clinic. The minority are going to be gelsolin, which starts in the face most of the time, ApoA1, which is really more of the kidney problem, and then extremely rarely AA, and then some of them are going to be of the wild-type TTR. And the TTR comes in two flavors, as you heard from Michelle. It's either going to be genetic or acquired, and to make the differentiation, you do the genetic test, and you get to the correct diagnosis, which is important with an autosomal dominant disease because you do have to counsel and you do have to test the rest of the family members. Now, this transthyretin, as you heard before, it's made mainly by the liver, and that's why a lot of the treatments that we use target the liver. Actually, back in the 90s, the first treatment was liver transplant. So although there's nothing wrong with the liver, there's no cirrhosis or anything wrong with it, the treatment is just to remove the organ that's making most of this TTR. What's interesting is also that the TTR is made on in local organs, and more specifically, it is made in the brain by the choroid plexus, and it is made in the eye, in the retina. And the reason why this is important is because now we have changed the natural course of this disease and people are living longer. However, our treatment are mainly targeting the liver, so we are seeing more and more neurological manifestation with the CNS and the ophthalmological manifestation in the eye. Another thing that's very interesting about this disorder is depending on the gene variant that you have, and there's over 140 gene variant now that have been prescribed, the way the patient present is going to be very different, which makes it even more challenging for us to diagnose these patients. So for example, if you take an early onset V30M, a lot of these patients are going to have painful small fiber neuropathy, dysautonomia. And if you take a late onset V30M, they're not going to have a lot of pain. Actually, they're going to have weakness and heart failure. And in the early one, you're not going to have heart failure, by the way. And then in the V122I, there's very little neuropathy, but a lot of heart failure and carpal tunnel syndrome. So very important to keep an open mind that amyloid can present in different fashion depending on the TTR variant that you have. Another thing that is interesting about this condition is that it was first, by the way, described in Portugal, which is an area where it's endemic, especially with the V30M. And then in Portugal, if you look at the patient population, they start very early, sometimes in their 20s and 30s to have symptoms, not uncommon. However, if you take another country like France, they start in their 40s and 50s with the same variant. So a very interesting thing that where you are also determine when the disease start. And in our patient in the US, the V30M also present in their 50s and sometimes 60s and sometimes even later. The other thing is that depending on which organ is involved, your survival is different. So T60A, which typically affect the heart and the autonomic nervous system and the nerve, but more frequently the heart, have a less chance of survival than for a neuropathy that typically affect, or for a variant that typically affect the nerves, as you can see here. Now, you've heard before that this is a multi-organ disease, which makes sense, right? You have the TTR that is produced by the liver and then secreted in the blood, and it's going to circulate in the bloodstream and reach all different organs in the body. So many organs are involved, especially as the disease progresses. And then when you see something like that, you have to think about a condition like amyloidosis. Now, neuropathy is common in the general population, and if you're going to think every patient with neuropathy is going to have amyloidosis, you're going to be disappointed, and then eventually you're going to give up. And that's the reason is less than 1% probably of patients with peripheral neuropathy have a condition related to amyloidosis. So because of that, we have looked at what are the red flags that could suggest that we are dealing with an amyloidosis. And one of those things is a rapid rate of progression of the polyneuropathy. So if you look at the idiopathic neuropathy, which is one of the more common, or diabetic neuropathy, which is the most common, and CMT, which is Charcot-Marie-Tooth, and it's a genetic neuropathy, is the second most common. None of these neuropathy progress rapidly. And when I say rapidly, meaning, a patient has numbness, tingling, burning sensation in the toes, a year later it may spread to the foot, and they don't have any balance issues, they're not falling, they don't have a foot drop. That's a slow progressive neuropathy. And you examine them from one year to another, and there's really little difference in their exam. However, a rapidly progressive neuropathy is a neuropathy that they start having numbness and tingling, exactly the same as an idiopathic neuropathy or diabetic neuropathy. But, 6 months later, they may start having balance issues, or a year later. And then there's going to have a foot drop. And when you examine them, you're going to see a significant change from one exam to another. So this is what we mean by a progressive neuropathy. Another thing that you see in amyloidosis is early autonomic dysfunction. Whenever you have autonomic involvement and neuropathy, amyloidosis should be the top of your differential diagnosis. There's really not a lot of condition that can cause these two that you see in the adults. So men frequently have erectile dysfunction, and a lot of time they're not going to volunteer that, so you have to ask them about this. Lightheadedness, so changing position. If they're laying down and they stand up, they're going to feel lightheaded, and if it's severe enough, they may faint. And then, of course, change in bowel movement. So anybody who has diarrhea that wakes him up at night, 3, 4, 5, 6, 8 times sometimes, that is most of the time is going to be amyloidosis. I've never seen this condition where people wake up at night several times to go to the bathroom and it's not amyloidosis. So this is a really good clue. Obviously, constipation, gastroparesis, vomiting, feeling full early, and all of those will lead to weight loss, by the way. So weight loss and neuropathy is very suspicious for amyloidosis. A lot of our patients go and get cancer screening, etc., and they don't find anything. But if they look for amyloidosis, they may find that. We talked about bilateral carpal tunnel syndrome, which is also a red flag. The challenge with this problem is that it's common in the general population as well. So not everybody with bilateral carpal tunnel syndrome are going to have amyloidosis, and obviously most of them actually will not. But if you do have a combination of things, if the carpal tunnel syndrome is severe and it keeps getting worse, even if after surgery, that's a red flag for me as well. Obviously, a family history of either sudden cardiac death or carpal tunnel syndrome and heart failure or neuropathy, all of those should be pretty straightforward, where you have to look for amyloidosis as well. Evidence, as we discussed before, of multi-organ involvement, cardiac, musculoskeletal, eye, especially vitreous opacities that don't go away. And then any lack of response. So let's say you diagnose the patient with a different condition, like an autoimmune condition, and you treat it and it doesn't get better. Well, you have to stop and think about what else it could be. This picture here shows you the rate of progression. And as I mentioned before, we looked at diabetic neuropathy and CMT versus hATTR polyneuropathy, and it's much more rapid progressive in people with hATTR versus those patients like really stable 1 year to another. Now, what are the first manifestation of the disease? From a neuropathy perspective, we're a little biased because they're going to come with neuropathy, but many people will have dysautonomia, carpal tunnel syndrome, and about 50%, which is interesting. A lot of patients start with this symptom sometimes years before the onset of the systemic amyloidosis or the diagnosis of systemic amyloidosis. And another thing is that a lot of time, if you ask the patient who have bilateral carpal tunnel syndrome, they will have other system involved, like the autonomic nervous system, neuropathy, cardiac, or GI. This is an interview at the time of diagnosis. Neuropathy is 100%. Again, we are at the neuropathy clinic. But you can see many patients will have multi-organ evidence of failure, even early on when you see the patient. So always do a careful review of system and think about the red flags. Now, another thing is that if you look at patients with neuropathy of unclear etiology, and we've heard a little bit about this concept from Dr. Kittleson, talking about looking at HFpEF patients and 15% having ATTR. Neuropathy, it's a little bit lower, but you do have about, in this study, we have found about 2% that had a TTR variant that was not suspected necessarily. So a low yield, lower than the HFpEF, but still a yield that can change and alter the life of patients. Misdiagnosis is very common in amyloidosis related to neuropathy, which makes sense because this is a rare disease, and most people may see like 1 or 2 in their whole career. So, however, again, when we have multiple organ involved, you have to think about it and check for it. So, what are the other things that are people misdiagnosed at? Usually idiopathic neuropathy, diabetic neuropathy, autoimmune condition, alcoholism, etc. So, all of these could be misdiagnosis. So you have the patient, what blood tests you're going to do. This is after diagnosing the patient. BNP and troponin are things that I do, but I always send the patient to the cardiologist. I'm not an expert in cardiac disease, and I want them to get screened. Every now and then, I may order also an EKG, echo, and PYP, just because it may take like a few weeks, and I can expedite the workup for the cardiologist. So when the cardiologists see our patients, they already have most of the workup done. You do want to make sure that the kidneys are not involved, which is not typical in ATTRv, by the way. As Dr. Kittleson said, immunofixation and free light chain are extremely important. You cannot make a diagnosis of ATTRv amyloidosis, even if you have the variant, the pathogenic variant. If you have abnormalities in those, you have to make sure that you're not dealing with AL. Treatment is very different. Obviously, AL is caused by a clone of plasma cells, and you target them with chemotherapy, versus ATTRv, which we'll talk about stabilizers and silencers in a little bit. Another interesting thing is that you can actually check the TTR in the bloodstream. So it's called still pre-albumin in most labs. And it's going to drop when you start people with silencer, and it's going to go up if you put people on stabilizer. And if you have a patient who's severely affected, actually the prealbumin is going to be low because it's not stable. So when you measure it in the bloodstream, it's going to be low. We also look for other things like B12 and hemoglobin A1C, just to make sure there's no other reason for the patient to have neuropathy. And the serum neurofilament light chain is something that we are doing as part of research. It does go up with nerve damage. It's not specific, so if you have a stroke or something else, it's also going to go up. But it does respond to treatment. So people who are not treated, as you can see here in this patisiran study, this is the baseline. Everybody is higher than the healthy patients. And when they're treated, the blue is the treated here, the serum neurofilament light chain will go down. However, in the placebo group, it will keep going up. So this is another thing that is kind of really mainly research, but you can test it in your clinical practice as well. So how the diagnosis is made, we talked about when to suspect it, and this is what Dr. Kittleson mentioned, which is the pattern recognition. And then you suspect this condition, and then you do the genetic testing, the SPEP, unifixation, and free light chain. So this is what we do when we suspect amyloidosis, because these are the two most common causes of amyloid neuropathy. And then you have four scenarios that you may encounter. You have the TTR VUS, no gammopathy. And when you have a VUS, you don't really know if it's causing the disease or not because it has not been described prior. So you have to get a tissue biopsy. Or if you have TTR pathogenic variant, and as we mentioned, you have a gammopathy. So you have, for example, an elevated lambda light chain, or an IgA lambda or something like that, then in those cases, you have to get a tissue biopsy to determine whether you have amyloidosis or not. And you have to recall that tissue biopsy is not 100%. So a lot of times, if the suspicion is high, we may end up doing multiple organs, fat aspirate, skin biopsy, nerve biopsy, heart biopsy, and so forth. And then the best scenario is if you have TTR pathogenic variant, but no gammopathy, then we do directly a PYP scan. And if it's positive, then you don't even have to get tissue anymore. But if it's negative, then you have to go back to the tissue. And then TTR negative or no gammopathy, then you're not dealing with any of those two. You have to look for other conditions that can also cause amyloidosis. So how do we manage these patients? Same thing with, the heart disease, you manage the TTR itself, and you target also with other medication, diuretic, etc. Same thing here, we're going to talk about treatment of the symptoms, the lightheadedness, orthostatism, the diarrhea, the pain, erectile dysfunction, etc. And we have treatment that target the TTR, and Dr. Kittleson already mentioned those treatment, but I will go a little bit more in details regarding how we study them in the neuropathy world. So currently, there are 3 drugs on the market that are approved for neuropathy, and these are patisiran, vutrisiran, and eplontersen. And vutrisiran has the benefit of also being approved for cardiac ATTR, which makes it, you can prescribe it if the patient has heart or neuropathy from V122I, or ATTR wild type as well, which is very interesting and exciting to me. The other 3 that are available in the US, but not approved for the neuropathy, tafamidis and acoramidis are approved for cardiomyopathy, and the diflunisal is off-label, but also works on the neuropathy and the heart failure as well. And then in the future, we may have more medication. Tolcapone, the interesting thing about it, it does have a very good penetrance to the CNS and hopefully to the eye as well. And then gene therapy, antibodies, etc. So really a breakthrough in 2018 for our patients. This has changed the way, the natural history dramatically, like an amazing impact on patients. If you see patients before and after these drugs became available, you know what I'm talking about. People used to die a terrible death, cachexia, diarrhea, heart failure, etc. And now we very rarely see those anymore. And in 2018, both of these studies, one on patisiran, the other one on eplontersen, comparing to placebo, show significant benefit of patient going on the treatment. So what these drugs do, they reduce the production of the TTR by the liver by interfering with the RNA, whether it's with the small interfering drug or whether it's with the antisense oligonucleotide. And it sees you drop the TTR by about between 70 and 80%, the circulating TTR in the bloodstream. And this also reflects clinically. So if you look at the neuropathy of these patients, it's improving in the patisiran group. The quality of life is also improving. And in the inotersen group, it slowed down the progression compared to placebo. Really significant change. I mean, this is dramatic. You don't really see that in neurology a lot. So amazing changes and improvement for our patients. And overall, these drugs were safe. The problem with patisiran was an IV. You have to pre-medicate patient. The problem with inotersen, you have rarely thrombocytopenia, which can lead to death, and you have to monitor weekly. So kind of a not very good safety profile, unfortunately, for inotersen, and overall safe, but a little bit inconvenient with the patisiran. Okay, so we've been using these drugs for a while now. Do they lose benefit? And it doesn't look like they lose. You see the TTR suppression continues for many years after the treatment. And not only that, this is up to year 5. You see the neuropathy is really stable and the quality of life is really stable. So 5 years later, things still look very, very good, really amazing things. And the other thing that you have to note is that if you start treatment late, so these are the patients who are on placebo and then went on the open label, they stabilize, but unfortunately what is lost is lost. So the organ damage, unfortunately, was irreversible at this stage. So you really want to try to diagnose patients early. And this is why we're doing this talk, because we're obsessed about finding the patient as early as possible and then starting treatment as early as possible. And this is a survival probability. Obviously, these are neuropathy trial, but you can see a patient, compared to placebo, 5 years later, 50% would die versus people who are on drug, more than 80% would survive. So really dramatic change for survival as well. Now, the good news is that we have a silencer version 2 that are much more convenient. So eplontersen is given once a month. You don't have to monitor the platelet or the blood count or the kidney or the liver. So this is great. This is eplontersen, sorry. And vutrisiran is given once every 3 months, and you don't have to pre-medicate. So vutrisiran is the new version of patisiran, if you want, and eplontersen, the new version of inotersen. So really dramatic things. And these drugs really kind of achieve the same thing. You see the vutrisiran was lowering the TTR even a little bit better than the patisiran, actually, in this study, more than 80%. And the other thing, very quickly, within 3 months, you're reducing the TTR, or within 3 weeks, take that back, really dramatic. And then with eplontersen, a little bit slower and the drop of the TTR, but still kind of very dramatic reduction in the TTR, about 80% and sustained. And these drugs also, again, do the same thing. They improve dramatically the quality of life and stabilize the neuropathy for both eplontersen and vutrisiran. So these are the 2 preferred drugs at this time that we give for our patient with neuropathy. So thank you for listening. I'm going to do the post-test clinical vignette. Now, I didn't really address the, so just to recall, this is a 70-year-old man who's already on stabilizer. So let's assume he's on vutrisiran or eplontersen and has been doing pretty good for the last 3 years. The cardiac involvement is present, but it has not been symptomatic in this patient. And then this patient is wondering, should I switch? And the answer should be, let's see. No, let's not switch. Let's use both. The more, the better. Or let's switch because oral medication is more convenient. Repeat the cardiac workup and see if things have changed. And if they have changed, we can switch therapies or add diflunisal. This is off-label, but it's cost-effective, meaning it's cheap. and then reassure the patient that he's on adequate therapy and no change is necessary. These drugs have been shown dramatic improvement. So let's see what the answer is. Okay, so we're able to convince you that some patients should be reassured. That's great. Still, some of you think that we have to repeat the cardiac workup and see if things have progressed. I mean, the issue is that well, maybe Michelle can talk about this, the issue. Add diflunisal, add a different stabilizer, and then switching. It's the least, which is, I think, is good. Okay, so I have to answer the question correct here.
Yes, please tell us the right answer.
Well, the right answer to me is to continue that, this patient has been doing stable for 3 months, right? For 3 years. And my approach to things that if it's ain't broken, don't fix it. That's number one. Number two, the silencer are excellent drug. I mean, as I've showed you, survival over 5 years, although that was not a randomized trial, but the effect on the neuropathy is so dramatic compared to stabilizer. If you look at the old studies, like the tafamidis was studied for neuropathy initially. And in 2011, it didn't get approved for the FDA because they didn't feel that it really reached the endpoint. So things have really, the stabilizer, I think, are really great for neuropathy. And I'm not a cardiologist, but I do think they also work very good on the cardiomyopathy as well. The combination therapy, this is a tricky subject. We don't have any proof that combining treatment is really superior, and it may not be. We did a study retrospectively looking at our data, and we found that about 40% of patients are ending on combination therapy. So really something that is not recommended or studied. We found that it was safe, so we're not harming the patient, which is obviously the most important thing. But we did not see really a difference in hospitalization or mortality. And then switching the stabilizer, we said, no, we don't like that. Things are looking good. Repeat the cardiac workup and see if there's progression. This is an interesting concept. And studying the progression is a little bit hard. I'm going to let Michelle comment on that. Suggest adding diflunisal. This is kind of the same as number A, but the difference is that this is going to be more cost effective. You're not going to run into insurance issues because insurance now are really, I think, clamping down on people who are on combination therapy. So to me, and I hope, Michelle, you think the same thing, I'm going to reassure the patient and tell them you're doing fine. Let's not change anything.
Yes, I totally agree, Shafiq. Now, I wish I disagreed with you so we could have a controversial discussion, but I think what you said is exactly right. Let's move to the next slide, which says questions on it. If you can go back to slideshow mode. And then put up that slide that says perfect. This is and the questions are gonna come in fast and furious. So I'm gonna punt them to you or me, depending on who's the right person. But I'll say to begin with, I completely agree that there is no clear evidence of benefit of combination therapy with a stabilizer and a silencer that has not been proven better than single therapy alone in either the neuropathy or the cardiomyopathy. And while there's no harm, that's exactly how I describe it to patients. I say, I cannot medically tell you it is better to be on both. And also, if you think about it, physiologically, it doesn't quite make sense to be on both. Because if you're silencing it, why do you need to stabilize what little left is left? And if you're stabilizing it so well, what's the point of silencing it too? So the combination therapy doesn't quite make sense pathophysiologically. And also, as you know, there's no trial evidence. So what I tell patients is you have two options, exactly as you said. If it ain't broke, don't fix it. Or because I've told you there is no harm, some patients would say, I want everything because everything's better than nothing. So often it comes down to the patient's temperament in a way. If they're an ain't broke, don't fix it, listen to the doctor type, or if I want everything because everything's better than nothing type. And I do worry, not necessarily for the health of the patient, because there's no harm in combination therapy, but I worry about the burden on the healthcare system because tafamidis, acoramidis are about $250,000 a year list price, sticker price, and vutrisiran is about $700,000 a year sticker price. And often, as you said, insurance companies aren't clamping down, to my mind, as fast as they should. And Medicare Part B versus Part D often is a loophole that gets these things covered because vutrisiran is a different part because it's administered in a healthcare setting. All of that to say, I think it's a tough. It takes a lot of discussion with patients and shared decision making. So I think we are completely aligned and on the same page regarding the choice. Pick one, choose that one based on cost, neuropathy, and patient preference of access, route of administration. So I'm going to give you the first question. So get all your questions in so we have time to answer all of them. And the first question that came in about the neuropathy is this. So when you counsel patients to start these medications, tell us about does the disease still progress when you give these silencers or does it improve? And do they start with sensory and get more peripheral or autonomic and get sensory? How do you manage their expectations of the course of disease on therapy?
Yeah, that's a great question. And it's always important to set the expectation for the patient, right? Because this is going to help you really on the long term. So you don't want to, well, you don't want to overpromise, okay? So that's number one. I don't tell people you're gonna necessarily, your foot drop is gonna resolve completely. And then the other thing is that it really depends on when you are diagnosing the patient. Uh, if the patients are pretty advanced, it's tricky because all you're gonna hope is to really slow down the disease progression and hopefully halt it. If the patient are diagnosed pretty early on, then there's a high hope that you're gonna improve actually the symptoms, not only stabilize them. But what I try to tell the patient that what we're gonna do first, we're gonna try to stabilize the disease and slow down the progression. And then if you improve, that would be great. And the good thing is that with these current drugs, a lot of time we do see improvements. But again, I don't want to overpromise because then the patient is going to say, well, you said I'm going to get better. I'm not getting better. What's going on? Is this drug working? Is it not drug working, etc. So because the issue is that the disease probably starts many, many years before we are diagnosing it, even if they don't have symptoms. That's the thing, that the amyloid is being deposited in the body, and then there's a certain threshold where the symptoms appear. But it doesn't mean that, oh, the disease just started this second. It's probably started many months or years before we made the diagnosis. So that's number one. Number two, how do the patient progress from small fiber neuropathy to large fiber neuropathy to autonomic dysfunction? It really varies from one patient to another and from the variant to another. So for example, the T60A, I've noticed a lot of them have a lot of dysautonomia, GI issue, and very little neuropathy. And they also have heart failure. Where the V30M, they're going to have neuropathy if they're early onset and dysautonomia. And if they're later onset, they're going to have more weakness. And sometimes they may be diagnosed with ALS or motor neuron disease. So the presentation is variable. But the good news is that we are diagnosing patients earlier and earlier. We have a lot of family members who don't even have symptoms yet. And that's another, very large subject that we can discuss if you want. And people who have the variant but don't have symptoms yet, what do we do? So things are looking much better from, let's say, 10 years compared to 10 years ago.
That was super helpful. Now we have another fantastic question in the chat. Speaking of earlier diagnosis, so I'll take this one. The question is there ATTR screening for individuals over 65 as part of the annual medical checkup? That's a phenomenal question. And I think there's actually studies ongoing for routine screening of higher risk populations. So one of the variants that's most common in cardiomyopathy in the United States is the V142I. That variant is in fact present in 3.4% of Black Americans. Now, that does not mean that 3.4% of Black Americans will all get ATTR-CM by their 70s or 80s, but it means that's a vulnerable population. But there is incomplete penetrance, variable expressivity. But those are patients who may be screened. So who should you screen that walks into your office? Not all comers. That is just not cost effective. Who you should screen, have a high index of suspicion, is those older patients, as you said, 60s, 70s, 80s, who have dyspnea, edema, preserved ejection fraction, increased LV wall thickness that doesn't quite make sense, those musculoskeletal manifestations that seem like they don't relate, but they probably do, like the bilateral carpal tunnel at an older age, spinal stenosis, that peripheral neuropathy when the family history. So it's really about this pattern recognition. Don't screen everyone. But if you're thinking to yourself, this patient has heart failure, think to yourself, could this be an underlying cause of their symptoms? And then I'm going to just give a brief blurb on how we would do the cardiac screening in asymptomatic carriers. So, asymptomatic carriers come to us in one of two different ways: cascade screening of first degree relatives who have a pathogenic TTR variant because their family one was affected and got tested, or they got a carpal tunnel surgery. They got a spinal stenosis surgery, and that orthopedic surgeon was hip to amyloidosis, asked the pathologist to look, and they find it on one of these orthopedic surgical specimens. Those are the two classes of patients who would undergo screening. How do we do the screening? Well, it starts with, is there anything wrong with their heart? For a gene carrier, we typically say 10 years before your family member was diagnosed, let's start your annual screening because we don't want to miss or delay the diagnosis. For someone with the carpal tunnel or spinal stenosis specimen, start it right then, because those conditions typically precede cardiac manifestations by anywhere between 5 and 7 years. How do you screen? Look for if there's something wrong with the heart. How do you know if there's something wrong with the heart? Echo, is there increased LV wall thickness? Biomarkers, is there an elevated NT-proBNP or high sensitivity troponin, which will be up, not because of CAD, but because there's infiltration of this thing into the muscle. If any of those are abnormal, then do your dedicated technetium scan. Repeat that annually to make the diagnosis. So then, and leading off that question then, Chafic, I have one for you coming from the chat, which is, when do these patients need to see a neurologist versus is this a condition that could potentially be managed by a primary care physician?
Oh, the easy answer is to hopefully send all of these patients to somebody who specializes in amyloidosis. I mean, even many of our colleague neurologists are not very comfortable with amyloid neuropathy because it's rare enough that you may not accumulate, a large number of patients to have experience with it. So now, for the people who are traveling from far away, I try to always correspond with a local neurologist. It's always good to have somebody local, just in case there's something urgent, or to coordinate sometimes with the infusion, with the injection, with the treatment administration. Sometimes, from one state to another, there's a little bit of difficulty getting those. So, we're always, I don't think any of the amyloid expert have ever denied helping a patient with amyloidosis. I've noticed that how amazing and open and the collaboration between, because we do also want to try to teach our colleagues about this condition. So I do think that everybody should really be seen by neurology and cardiology. Obviously, cardiology is a little bit more important, but I think the neurology input is also very valuable. So that's what we do, at least in our clinic, and I think in your clinic as well, that most people are seen by both. Obviously, if they have an MGUS, they will see a hematology. If they have kidney involvement, they will see the nephrologist, and so forth. One thing that I've noticed more recently, and we may have to end soon, is, as you just said, the orthopedist. So I've had a few patients referred for just carpal tunnel syndrome, and they don't have any evidence of amyloid in their nerve or their heart. And I think these can be a little bit challenging. So maybe just in 30 seconds, you can tell me what your approach is to these patients.
Yeah, no, I just want to make sure everyone heard what he said. The cardiologist is more important than the neurologist. I hope you guys all heard that. That came from the neurologist, and this is being recorded. So thank you for that, Shafiq. So, yeah, so I think the screening protocol should be echo and biomarkers. Is there any suggestion of disease? And so, if there's pathological evidence on the carpal tunnel specimen, then go forward with the evaluation. Now, say the orthopedic surgeon is just really aware, but didn't send a specimen for pathology and is just sending to you because there was bilateral carpal tunnel. Honestly, in that situation, go back to the pathologist and ask them to rescreen it. They store those specimens. So start with the tissue diagnosis before you put them down this path of going through a cardiac screening. Now, about 30 to 50% of those carpal tunnels, bilateral and older people, probably are amyloid, but establish that before you assign them that diagnosis. You know, I think that's probably all we have time for. We're at 15 minutes past the hour. We'll just go to the last slide here. Thank you, everyone, for participating. Good for you. You stayed until the end of the webinar, so you can complete the evaluation about how much you learned in the next 6 months, so you can get your certificate. But thank you so much. It's been such a pleasure to share wisdom with you, and I learned so much.
Thank you, Michelle. That was great.